My name is Louis Aldawi, and I'm a consultant in transfusion medicine at Northern Ireland Blood Transfusion Service, NIPTS. Today we are going to talk about platelet alloimmunization. With regard to immune cytopenias, I have listed red cell and platelets for comparison. We have autoimmune hemolytic anemia, and the platelet equivalent would be autoimmune thrombocytopenia. We have hemolytic disease of the newborn, and the platelet equivalent will be fetal alloimmune thrombocytopenia. We have transfusion red cell alloimmunization to red cell antigens, and we have transfusion platelet refractoriness due to HLA antibodies. We have drug-induced autoimmune hemolytic anemia, and we have drug Purpura. We have delayed hemolytic transfusion reaction due to red cell blood transfusion, and we have post-transfusion Purpura. The platelet alloantigens, HLA class 1 antigens are the primary inciting antigens for transfusion platelet refractoriness. We also have human platelet alloantigens. They were called platelet-specific antigens, but they are not specific anymore because we know that they are present on endothelial cells and some other tissue. They cause post-transfusion Purpura, neonatal alloimmune thrombocytopenia, and they may or may not be linked to platelet hyperreactivity. We have the ABO blood group, which is present on platelets. However, they don't have a tremendous role to play in transfusion outcome or refractoriness. Platelets adhere, secrete, aggregate, and in order to do that, they need to have integrins on. Here is glycoprotein 2B3A, and you can see there are, the glycoprotein obviously binds fibrinogen and von Willebrand factor. You can see there are some areas on the glycoprotein where there are amino acid substitutions, and that would give rise to platelet-specific alloantigens. This is glycoprotein 1B9, and you can see many alloantigens. Human platelet alloantigens, as we said, they are not called platelet-specific antigens anymore because they are present on other tissues. They are conformational immunogens, which means the conformation of the protein decides whether it's immunogenic or not. They give rise to alloimmune-mediated thrombocytopenic disorder of post-transfusion Purpura, fetal or neonatal alloimmune thrombocytopenia, and platelet transfusion refractoriness. I have listed in this slide the 5 most commonly encountered platelet alloantigens. You can see the original names and the important glycoproteins and the amino acid substitutions responsible for these antigens. Now we can sequence these proteins and type individuals using DNA. In the past, we used anti-sera, which was suboptimal. Here are the immunogenetic studies on the 5 most commonly encountered platelet antigens. As you can see in the white Caucasian population, human platelet antigen 1A is the most immunogenic, while in African American and Asians, it is a human platelet antigen 4A. It's interesting to note that even though human platelet antigen 1A and 1B are quite similar, the only difference is one amino acid, leucine, for human platelet antigen 1A and proline for human platelet antigen 1B, but the difference in the immunogenetic ability is quite remarkable. Ray Scholman was an immunohematologist, and he saw a patient who was a lady who had blood transfusion and came after about 7 to 10 days covered with Purpura. They checked the platelet count, and she was quite thrombocytopenic, and then they checked the serum for alloantibody, and there was an alloantibody. The thrombocytopenia recovered and the alloantibody persisted. This was the first report of post-transfusion Purpura, and this led to many interesting studies about autoimmunity and human platelet antigens. So post-transfusion purpura is characterized by sudden onset of severe thrombocytopenia. It can be 12 to 24 hours. The enigma of platelet transfusion purpura is an alloantibody to human platelet antigen. The alloantibody will develop and persist despite the resolution of thrombocytopenia. Post-transfusion purpura is almost exclusively seen in females. The typical patient is a lady who was sensitized to the human platelet antigen 1A in a previous pregnancy, and then she was transfused about 3 to 52 years later and developed the post-transfusion purpura. There are only few cases of male reported to have post-transfusion purpura. The clinical presentation is petechiae, wet purpura, as well as bleeding from multiple operative sites. This is a review of 45 cases of post-transfusion purpura. The platelet count was quite low, below 5,000, and the thrombocytopenia developed very quickly, persisted for 7 days, and in some cases it persisted for 35 days. Anti-HPA-1A was responsible for more than 90% of the cases, and it was associated with severe acute febrile reactions because it's almost always associated with anti-HLA antibody. Unmatched platelet transfusions were ineffective, obviously, because the alloantibody will destroy the unmatched platelets. And of the 8 patients transfused with platelets, they had thrombosis. So it's very important to be wise in your decision in transfusion. We don't transfuse patients with post-transfusion purpura unless they are bleeding. And now we can do ELISA testing on a daily basis to detect antibodies against any of these antigens. A treatment of post-transfusion purpura. In the past, we used steroids and plasma exchange. Nowadays, IVIG, intravenous immunoglobulin, is a treatment of choice. We can give platelet transfusions if necessary, which means if the patient is bleeding and has to be HPA matched and HLA compatible, as almost always HLA antibodies are present. Now, with regard to future elective surgeries, if the patient with known post-transfusion purpura is scheduled for surgery, we use autologous blood and we use antigen-negative platelet units. Now, in most transfusion centers, human platelet antigen 1B units are available off the shelf. Any woman who has a child with neonatal alloimmune thrombocytopenia should be cautioned of risk of post-transfusion purpura in future with transfusion, because as we discussed, the patient's pregnant lady who had a child was positive for human platelet antigen 1A, and she was negative for the antigen. She must have been sensitized, and the chance of developing post-transfusion purpura if she gets human platelet antigen 1A positive blood or platelets is quite high. Now, with regard to the mechanism of action, there are multiple theories and nothing is certain. One of the theories is hapten-like mechanism, which means the antigenic material in the stored blood or platelet can become solubilized, and upon transfusion they get attached to the patient's platelet and they convert it from HPA-1A negative to HPA-1A positive. And then obviously if there is anamnestic immune response, an alloantibody will destroy the autologous platelets. Another mechanism is the innocent bystander, and with regard to delayed recovery, when the platelet count does not recover until after 35 days, a mechanism of phage cloning is possible. Now we gonna talk about the fetal or neonatal alloimmune thrombocytopenia. The typical scenario would be a mom who is human platelet antigen 1b, 1b, and a fetus who has got human platelet antigen 1a, 1a. The mom will obviously develop an alloantibody against the fetal platelets, and this will cause thrombocytopenia as early as 10 to 12 weeks in pregnancy. Now, it's very important to recognize that even though fetal or neonatal alloimmune thrombocytopenia is the equivalent to Rh disease, Rh disease will not happen in first pregnancy, while NAT or neonatal alloimmune thrombocytopenia would happen in the first pregnancy. And the reason for that, because there is much more antigen shedding from the syncytioplast derived from the fetus, which contains antigen, and this can be detected in maternal blood by 9 weeks. Just to summarize, fetal or neonatal alloimmune thrombocytopenia is caused by alloantibodies to human platelet antigen. Most cases are diagnosed at birth, so they're called NAT rather than fetal alloimmune thrombocytopenia, and they can happen in first pregnancy. The most common antigen is human platelet antigen 1A, and it occurs about 1 in 1,000 to 2,000 pregnancies. The clinical characteristics actually might cause serious fetal consequences. Intracranial bleed can happen up to 20% of cases, and 10% can be fatal. And in the subsequent pregnancies, the risk is almost 100%. If the fetus bleeds into his brain, they develop porencephalic cysts, which are quite detrimental to normal brain development. Now, as you can see in this slide, that 3% of the population are 1B, 1B. So 3% of the population are at risk of alloimmunization to 1A, while 70% of the population are 1A, 1A, so 70% are at risk of alloimmunization to 1B. How do we work up suspected case of NAT? The common scenario is that we receive a call in the transfusion center from the pediatric consultant or registrar. A baby was recently born was covered with purpura or petechiae, and they did a full blood count. They found him to be thrombocytopenic, and the question whether this is a case of NAT or not. The first thing we ask him to do is to send a maternal blood sample for alloantibody detection, and we also do genotyping of the fetal and the mom for the platelet alloantigens. And if we detect the alloantibodies, this will be diagnostic of a case of NAT, and then we will treat as if we have a diagnosis of NAT. Obviously, if the platelet count below 30, we will transfuse the newborn, and we give IVIG to the mom. And if the platelet count is below is over 30, but the patient had a previous pregnancy with NAT, then the threshold will be increased to 50. So we try to keep platelet count over 50. Obviously, if the newborn has intracranial hemorrhage, we will transfuse regardless of the platelet count. We don't screen antenatally for FNAT because it's not proven to be cost effective. And we don't utilize newborn sample for antibody testing because it's frequently undetectable. Now, if the alloantibody was not present, but the genotype is typical, which means we couldn't find the alloantibody, but the patient is, or the newborn is severely thrombocytopenic, and the mom is negative for human platelet antigen 1A, and the baby is positive, then obviously we would still treat it as a case of NATE, as sometimes you can't really find the alloantibody in, and the alloantibody will appear later. This is a case of FNATE, and the newborn had alloantibody to human platelet antigen 5B. With regard to platelet support, in the past we used washed maternal platelets. Platelets obviously needs to be available soon after delivery because the risk of bleeding is quite high. Now we can use human platelet antigen 1A and 5B negative because these are the most frequent antigens involved in the development of FNATE. Now also, so as we said, it has to be, the HPA should be absent, HLA antibodies should be absent, and CMV negative, and other donor requirements, like if we are giving transfusion to a fetus, it has to be irradiated. Now, this slide will explain the difference between transfusing a neonate with matched platelets or unmatched platelets. And when we talk about matched platelets, it's regard to the HPA. So if you transfuse a neonate with this recently diagnosed with neonatal alloimmune thrombocytopenia with unmatched platelets, there will be an increment in the platelet count, but it will drop quickly because of the alloantibody from the mom that would destroy the new platelet, which would have the same antigens that the alloantibody has developed to. Now, if you transfuse HPA matched platelets, which means negative for the antigen that the fetus has and that caused the neonatal alloimmune thrombocytopenia, the platelet count will improve and will stay high for a period of time. Now we'll talk about platelet refractoriness. It's almost always due to alloimmunization to HLA class 1 antigens. Well, obviously there are some clinical scenarios where you'll have platelet refractoriness like DIC, sepsis, fever, or splenomegaly, and ideally you should not really expect immune refractoriness unless you have excluded these clinical causes. With regard to alloimmune platelet transfusion refractoriness, it's very important to realize that the HLA system is quite polymorphic, and it's very difficult to match for all antigens and to get perfect match. If you get a perfect match, then obviously the success rate is 100%, but we sometimes actually have to deal with minor mismatch, and this will cause a failure rate of 8 to 35%. And sometimes if we can't really manage with HLA matched platelets, then we check for antibodies to human platelet antigen, as 8% of the cases would be due to alloantibody to human platelet antigen rather than to HLA antigens. Platelet refractoriness is rarely caused by APO antibodies. Now, it's very important to realize that having HLA antibody does not diagnose platelet transfusion refractoriness, because the only way to confirm platelet refractoriness is by giving HLA matched platelets and documenting an increment in platelet count. And this is obviously the opposite of NATE, where having alloantibody is diagnostic of NATE. Now we talk about prevention of alloimmunization. We limit transfusion exposure. For example, if there is no response to HLA matched platelet, you should not really continue to provide platelet transfusion, because that will just increase the rate of alloimmunization. We use pheresis platelets instead of whole blood, because in pheresis platelets we have one donor, while in the whole blood we have up to 4 donors for 1 unit of platelet. Leukocyte depletion is very important, and these are white blood cells. This study shows that if you have the control is normal platelets, and the other actually you've got 3 to 4 log reduction in the white cell population, and this will cause marked reduction in alloimmunization rate. What is our strategy for HLA transfusion? We match only for antigens A and B, HLA A and B antigens on the platelets. We don't match for HLA C because they are weakly expressed. We try to give perfect match for A and B, but as we said, it's not always possible. If we can't get a perfect match, or if it was not possible, then we could do platelet cross-matching, and this will increase the success rate for up to 80%. Thank you for your attention.